Hi, my name is Dr. Ronald Isoff. I'm an internist practicing medicine in Ottawa, and I've prepared a series of videos on the medical management of obesity. Today, I'm going to discuss bariatric surgery. Bariatric surgery refers to a number of operations that have been specifically developed to enable obese people to lose weight. I would like to start with a case presentation. A 25-year-old newly diagnosed diabetic man is referred to me for medical management. He is 5'8" tall, and he weighs 200 pounds, and his BMI is 30. So he's obese, but he's certainly not morbidly obese. What will you recommend? A medically supervised weight loss program, medications, or bariatric surgery? I'm hoping that by the end of this presentation, I will be able to convince you that bariatric surgery is an option that should be on the table on day one. I'll quickly go through some of the more common bariatric surgical procedures just to give you a rough idea of how they work, and then I'll go over them again in more detail a bit later. With the lap band, a ring is placed around the proximal stomach, and this restricts the amount of food that can pass from the esophagus to the stomach at any given meal. With a sleeve gastrectomy, the outer part of the stomach is resected, leaving a much narrower and smaller residual stomach. The gastric bypass is a bit more complicated. With this operation, the proximal stomach is separated from the rest of the stomach, leaving a tiny gastric pouch, and that pouch is hooked up to the small intestine. Food passes from the esophagus to the small stomach pouch and then directly to the small bowel. The remainder of the stomach no longer comes in contact with food. While it might seem intuitively obvious that these operations would work by restricting the amount of food that can be consumed at any given meal, it turns out to be more complicated than that. These operations actually modulate a number of hormones that affect both hunger and satiety, and that hormonal effect, rather than the small stomach pouch, appears to be the major mechanism by which these operations enable weight loss. For example, ghrelin is a hunger hormone that is secreted by the stomach. And when the stomach is removed, as in a sleeve gastrectomy, or bypassed, as in a gastric bypass, ghrelin is no longer secreted, and people feel much less hungry. Peptide YY, GLP-1, and GIP are other hunger hormones that are also modulated by these surgical procedures. I like ice cream in all forms and shapes. I also like butter on toast or with mashed potatoes. However, if you served me a bowl of butter with a tablespoon, I would not be tempted to eat it unless I was awfully hungry. After bariatric surgery, many foods that seemed delicious and irresistible before surgery no longer seem to have much appeal. 60 years ago, we didn't have any effective medications to treat stomach ulcers. This was long before the days of Zantac, Pepcid, and Nexium, and complications of stomach ulcers, such as GI hemorrhages and gastric perforations, were quite common, and they often had to be treated surgically. One of the operations that was used to treat those ulcers was a gastric bypass. Dr. Edward Mason was an astute surgeon who noticed that obese patients who had received a gastric bypass to treat their ulcers also often lost a great deal of weight, and they kept that weight off. In 1966, he started performing gastric bypasses on morbidly obese patients who did not have stomach ulcers. He is now recognized as the father of bariatric surgery. He recently died at the age of 100. In 1985, bariatric surgery had already been around for 20 years, and Lars Sjöström and his colleagues in Sweden decided to initiate a long-term prospective study comparing bariatric surgical patients with medically treated patients. Just for context, I'd like to point out that in 1985, when the Swedish obesity study was initiated, none of these medications had yet been introduced. None of the statins, ACE inhibitors, ARBs, protein pump inhibitors like Nexium, Prevacid, and Pantoloc, none of the antibiotics like Cipro and Zithromax, or even none of these antidepressants like Prozac, Paxil, Zoloft, Wellbutrin, and Effexor. None of these drugs had been introduced in 1985. Bariatric surgery has been around for a very long time, and it should not be considered new or experimental. We have better long-term data on bariatric surgery than on any of these medications. In the Swedish obesity study, 2010 bariatric surgical patients were carefully matched with 2,037 conventionally treated patients, and they've been followed ever since. After an average of 11 years, there was a 30.7% lower mortality in the surgical group. One of the findings from the Swedish obesity study was that there was a marked reduction in the incidence of many of the most common cancers. This was a complete and unexpected surprise. In this study out of Utah, nearly 8,000 surgical patients were matched with a similar number of medically managed patients. After 7.1 years, there was a 40% lower mortality in the surgical group. They also noted a large reduction in the incidence of cancer. In this recent review, this group from the Cleveland Clinic matched 22,000 patients who had undergone bariatric surgery with 66,000 carefully matched patients who didn't. After only 3.5 years, they found a 33% reduction in the incidence of cancer. This reduction in cancers, particularly amongst women, may well be the most important single health benefit of bariatric surgery. This is one of 13 randomized controlled trials comparing medically supervised weight loss programs with various bariatric surgical procedures. This particular trial was conducted by Dr. Phil Schauer and his group out of the Cleveland Clinic. 150 diabetic patients had agreed to be randomized into one of three arms. The first arm was assigned to a weight loss program, while the other two were randomized to receive either a sleeve gastrectomy or a gastric bypass. As you can see, the two surgical groups lost much more weight than the weight loss program group. And the A1C, which is a diabetes test, also dropped much more in the surgical groups. Over and above this, there were also marked improvements in blood pressures, lipid profiles, and above all, quality of life in the surgical cohorts. It's beyond the scope of this presentation for me to give detailed descriptions of the differences between the various surgical procedures. Rather than that, I'm just going to review some of the more common procedures and give you a few comments on them. These are the four most commonly performed bariatric surgical procedures: the sleeve gastrectomy, the gastric bypass, the lap band, and the duodenal switch. The sleeve gastrectomy is by far the most commonly performed bariatric surgical procedure in the world. With the sleeve gastrectomy, the outer part of the stomach is lopped off, leaving a much narrower and smaller residual stomach. However, the sleeve gastrectomy that is performed today is radically different from the sleeve gastrectomy that was performed 20 years ago. The sizing and shaping of the residual stomach has changed. Different and much more efficient staplers have been developed, and several different types of reinforcement and buttressing techniques have been developed to prevent staple line leaks and bleeds. The net effect of these changes is that the sleeve gastrectomy, which was a very safe operation 20 years ago, keeps getting better and safer every single year. Many centers are now doing sleeve gastrectomies on an outpatient basis. Patients have their procedure in the morning and they are sent home in the evening. And some centers are now offering endoscopic bariatric surgical procedures. These operations simulate a sleeve gastrectomy, but the entire procedure is done with an endoscope that is inserted through the mouth. This requires no abdominal incisions at all. This is my former associate, Tom Lavin, describing the POSE procedure. He and his colleagues have been at the forefront of this type of research. The gastric bypass is a bit more complicated than the sleeve gastrectomy. As I described earlier, the proximal stomach pouch is separated from the rest of the stomach, leaving a tiny pouch, and that pouch is hooked up directly to the small intestine. This creates the alimentary limb. Food passes from the esophagus to the tiny gastric pouch and then directly to the small bowel. The remainder of the stomach no longer comes in direct contact with food. The acids secreted by the stomach mix with the digestive enzymes from the pancreas and liver and pass on to the small bowel, where the two limbs are connected to each other. This is called the biliopancreatic limb. Digestion does not effectively occur until the digestive enzymes from the biliopancreatic limb come in contact with food from the alimentary limb. I know that all this seems a bit complicated, but I would again like to reiterate that the main mechanism by which these operations work is from their effects on hunger and satiety, as opposed to the restrictive or malabsorptive effects of the surgery. With the lap band, an adjustable ring is placed around the proximal stomach, and that restricts the amount of food that can pass through it. There is a port that is attached to the abdominal wall. By ejecting saline into that port, the diameter of the ring can periodically be adjusted. The lap band has largely been abandoned because of an apparent lack of efficacy. However, there have been some recent studies out of Italy suggesting that the lap band may actually be more effective over the long term than we had previously thought. The key seems to be that patients and their physicians need to learn how and when to adjust the ring diameter. So much is dependent on the availability and quality of the aftercare. I think that we may well see an uptake in the use of this procedure in the near future. The duodenal switch is technically a more complicated procedure to perform, and there are significant risks of both short and long-term complications. Because of this, most surgeons tend to shy away from this procedure. Having said that, I've been following a number of patients who have had this procedure, and they are all doing very well. The duodenal switch has by far the best record for long-term weight loss, and it resolves metabolic complications such as diabetes and lipid abnormalities more effectively than any other surgical procedure. In my experience, patients who have chosen to have this procedure tend to be highly intelligent, critical thinking people. Each of them had gone through an enormous amount of research, and they went through great lengths and expense to find a surgeon who was willing to do it. These are two other procedures that have recently garnered a lot of attention. The single anastomosis duodenal ileal bypass is a newer procedure that has been performed in a number of centers, particularly in the US and in Spain. It is a modification of the duodenal switch, but it is simpler to perform, and it is hoped that this will be able to give the same excellent long-term weight loss and diabetes results as the duodenal switch, but with a lower incidence of complications. The jury's still out on this one. The single anastomosis gastric bypass, or mini gastric bypass, is a modification of the gastric bypass that is simpler to perform, and some claim that it may have a lower complication rate. This operation has become very popular in the Middle East, particularly in Israel and Iran, and it has also been done quite a bit in India. This operation is almost never performed in Canada or the USA. Which is the best smartphone? I have no idea, but one thing is perfectly clear. They are all much, much better than the phones we used 40 years ago. So what is the best bariatric surgical procedure? In the year 2022, there are excellent bariatric surgical centers in just about every country in the world. As a general rule, I suggest to patients that they accept one of the procedures that their bariatric center offers. If I lived in Canada or the US, I would probably opt for a gastric bypass or a sleeve gastrectomy. If I lived in Israel, Iran, or India, I might well opt for a mini gastric bypass. These cars are all much, much better than they used to be. They are safer, they have better gas mileage, and they require less maintenance, and they last much longer. This paper was recently published in The Lancet. It is a high-quality meta-analysis of prospective studies that compared the long-term outcomes of bariatric surgical patients with medically treated patients. It included over 170,000 participants. The conclusion was that bariatric surgery extended the average lifespan of diabetic patients by 9.3 years and non-diabetic patients by 5.1 years. And you may recall from one of my other videos that both the Diabetes Prevention Program and the Look Ahead trial demonstrated that medically supervised weight loss programs do not yield any long-term mortality benefit at all. Back to our case presentation. A 25-year-old newly diagnosed diabetic patient with a BMI of 30 is referred to you for medical management. What will you recommend? Patients who enter medically supervised weight loss programs suffer enormously from demoralization, humiliation, and depression when they invariably regain the weight that they have worked so hard to lose. They usually have their bariatric surgery delayed by at least 5 years and often indefinitely. At the end of 5 years, the insulin-producing beta cells in the pancreas have burned out, and the patient's diabetes, which was reversible, is no longer reversible. The patient will now require diabetes medications for the rest of his life. We now have some excellent medications that can treat both diabetes and obesity very well, so that's certainly an option. This Finnish study compared the one-year mortality from different surgical procedures. Bariatric surgery was shown to be even safer than gallbladder or prostate surgery or hysterectomies. Many centers are now offering outpatient bariatric surgery to diabetic patients who have BMIs as low as 27, that is 5'2", 150 pounds, or 5'8", 180 pounds. Why not consider bariatric surgery on day one, rather than embarking on a lifetime of medications, frequent doctor's visits, and lab tests with all of the costs, side effects, and inconveniences that would entail? Micheline is a registered nurse. When she was 44 years old, she decided to have bariatric surgery. She chose to have a duodenal switch because of its documented effectiveness in treating diabetes. She had tried innumerable weight loss programs, including the Optipass program, where she had actually lost 80 pounds. But each time she quickly regained all of her lost weight. She was particularly concerned about her diabetes, which she had found impossible to control, despite taking numerous medications. Her blood sugars have been controlled since the day of her surgery, and they have remained normal since then. The Lancet study would suggest that she may have extended her lifespan by 9.3 years. I'd worked with Rami for more than a year, and I'd never seen him as being particularly obese, certainly nothing like this picture shows. It might be because he usually wore a lab coat, or perhaps it's just the way he carried himself, but I did not appreciate how obese he was. He chose to have a sleeve gastrectomy, and this is a picture of him before and 1 year after his surgery. This is a photograph of Dawn and Oscar before their gastric bypasses. Dawn had her gastric bypass first, and she's lost 107 pounds. Oscar had his gastric bypass more recently, and he's lost 60 pounds so far. To access my other videos, go to youtube.com, enter Dr. Ronald Lysop, and tap on my photo. I can also be reached at rlysop@gmail.com. Thanks for listening.